So, as said, next talk, NAVA and stable ICU patient. And do you know what this means? Well, I don't want to get that message for any referent in a Congress situation because that was what I experienced yesterday. So if you get this information, a nightmare becomes true because that actually means that your presentation is not there where you want to have it. So that's the reason why probably some of you saw me fiddling around with my computer all the time, getting a lecture ready for today. And what it means is what you don't get is nice original data on NAVA throughout the whole ICU stay because that's not with me anymore. And I won't show you NAVA, how it works in a stable ICU patient, let's say with PMS data to underline that. So instead what you get is what I found on my computer, a bit of this and that, and a general view. And you have to judge that at the end when I'm through with my lecture. So what you're going to hear today and already heard are these topics here. So I think a broad range has already covered with regard to NAVA, in which set of patients, how to set it, how to think about PEEP while on NAVA. So we have a lot of that addressed. So the question, of course, is what I'm left to talk about. So what I did, I steal a little bit from here and there in order to get a presentation done. So let's get a step back because we had this discussion a lot of times already. What are the modes we use in our ICU or that are used if you look throughout your country? And that's what we see, what is used. The control mechanical ventilation, SIMV, pressure support ventilation, CPAP, and BiPAP APFV if you looked for Europe. And if you look how it is in the studies, if you do that, you are in a nice company, because that's what is done, accordingly, if you look for the Esteban studies, for example. So that means that with regard to the development of mechanical modes of ventilation, you are nicely reached the time period of the 80s. That's where we are. So all what left, or all what comes beyond, does not really reached, or has never reached really your ICU probably, and we are here now with NAVA and all the new modes, and we are looking forward to what's coming up next. But again, we are here when we look what we're really doing in our ICU. So that might mean that there is not much evidence, or there's not proven data in order to use really the modes, or it might mean that we just didn't feel comfortable in making a step forward. And we had, of course, the discussion already yesterday. One point would be, should we use this old build-up car in the 86, or should we go for a new one? Well, there are probably data that supports a new one, and but it is also a matter of taste if you want to stick to the 86 car instead. And we had a taxi today to the conference center with a huge old car, so that was very funny, but I wouldn't buy that anymore. So why don't we use controlled mechanical ventilation? There's a lot of reason to not use controlled mechanical ventilation, and one is the physiological or pathophysiological changes if you switch to a controlled mode of ventilation. And what you see is that the whole matching of ventilation and perfusion is changing, and you see that nicely in this film here. This is controlled mechanical ventilation. If it works and if it starts, it should, where ventilation is only distributed to the ventral parts of the lung, while if you are in spontaneous breathing mode, as you see here, ventilation is going downwards, and that leads to a match of perfusion and ventilation, and we heard a lot of that in the recent talk, that how important that is, and how cardiac function plays a role in that whole concept of delivering oxygen to the patient. So there are other reasons why we don't use controlled mechanical ventilation anymore. We go for spontaneous breathing or assisted modes, improvement of distribution of ventilation, improvement of oxygenation, reduction of atelectasis, improvement of hemodynamics, reduction in sedation, and last but not least, that's an upcoming topic. If you look at the Levine study in 2008, diaphragmatic integrity and disuse atrophy. I think that is an important aspect we have to focus on within the next years. And in Germany, even the pneumologists who were so prone to put in controlled ventilation, they tend to change right now. That's what I realized. So what are the problems if we go for assisted ventilatory modes? These are delayed response to in- and expiratory efforts. We heard a lot of that during these talks here. But just to focus on that again, there are so many complications related to that. Ineffective ventilation, hypoxemia, lung overdistension, dynamic hyperinflation, increased work of breathing, patient discomfort, fighting the ventilator, unnecessary usage of sedatives, opioids or muscle relaxants, dysfunction of respiratory muscles, and so on. So this is really something we really have to go into. No maintenance of natural biovariability, not adapted to the actual need of the patient, and not adjusted to changes in lung mechanics, either if you put them in different positions or throughout the day. So these are problems related to conventional assisted modes of breathing. Looking at a titration curve of NAVA, I like these titration curves a lot. What you see here, if you increase the NAVA level, we heard that yesterday as well, that it tends to have a stable tidal volume in a huge range of NAVA levels. So the patient is adjusting his electrical activity or his effort to the placed airway pressure defined by the added NAVA level. So that is important. And why is that important? If we have a tidal volume in a certain range defined by the patient, well, it is important because we probably are not able to do that in a daily clinical routine. We heard that yesterday, that if you place standard procedures, you might reach that. But this is a publication in 2008 where we looked throughout Germany how tidal volumes are applied in the country. And, well, the data is a little earlier, of course, 2005. Around 3 to 5, it was 80% above 8 ml per kilogram. So that is a very worrisome result we found there. So we are not in the range. So it would be nice to have a mode who adjusts the ventilator automatically driven by the patient. This is animal experimental data. It is, I don't want to go too deep into what we said. We changed the PEEP, we changed the NAVA level, coming from a controlled situation of ventilation. And what you see here in a healthy pig, it is, well, the pig chooses his tidal volume in a certain range. And of course, this depends on also the lung status. With the healthy, you have more variability in there. If it comes to the injured lung, the tidal volume, interestingly, goes down to this area where we feel that this is a lung protective situation, so about 6 ml or even below. And that's not defined by us, that's defined by the subject, since it is the one who is driving the ventilator. So how about the clinical data in standard situations? So there's not that much out, so we have to accept that right now. I just looked through the studies again in order to get the situation ready for here. 14 patients in a crossover design, as you see here, the Columbus study, where they compare pressure support to NAVA, pressure support set at 6 to 8 ml per kilogram, and NAVA adjustment was done based on the pressure support settings. And what I found interesting here, since they changed the support to 50% below and 50% above, the interesting part for me is the tidal volumes, as you see here during pressure support and during NAVA. While doing pressure support, of course, you have the effect of increased support levels compared to NAVA, where this change is less pronounced since the patient is decreasing his inspiratory effort based on the NAVA level set, or in answering the NAVA level if he's not wanting anymore. So how about aeration? And we heard a bit, or I told you a bit about the distribution of aeration. This is also animal experience. We did that in Uppsala, not published yet. And on the left-hand side, you see a baseline situation of a pig after lung injury, 6 ml, PEEP of 10. And what you should see here is that 2 hours later in this protocol, there was only a slight change in aeration of these depending lung areas. And if you look on the right-hand side, where we have the same initial approach, and looking 2 hours later, after ventilating with NAVA, you have here a high increase of aeration in this dependent lung areas. And that is also seen overall initial situation and after 2 hours. It's a lung injury which is less stable, but that was intended. So giving a chance to have an effect by the chosen mode of ventilation. And this is also nicely shown here. It's only an example what is going on. This is EIT data, so that's electrical impedance tomography data. And what you can see here, it's just briefly, you put in a belt and you're given a small electric currents. And what you can see, or should probably see here, is this is a controlled ventilation situation where you have a lot of ventilation upwards. So red is high impedance changes. And if you switch to pressure support mode, you see that there is a shift in the gravity point of ventilation towards the dependent lung areas. And if you go to NAVA, it is even more changing towards the dependent lung areas in terms of the gravity of ventilation. And that probably explains also changes in ventilation and perfusion matching and VAQ ratios, as you see here again. Not to go too much detail, healthy versus lung injury, initial situation, and then the situation under different circumstances, differing NAVA level and PEEP level. And with the healthy, of course, you don't see that much of a change because the lung is healthy. But with an injured lung, you have an increase of normal VAQ after switching to NAVA. So that probably supports the theory that the NAVA mode leads to a more synchronized, dorsally shifted ventilation. So what else? NAVA in critical ill patients, that's the study we did, a more observational study. I want to go into the exclusion criteria just so we can look at that, but 20 patients we have chosen here, included into the study. They had to be ventilated more than 24 hours, ability to breathe spontaneously, and of course they were on enteral nutrition via nasogastric feeding tube. And we put these patients on NAVA, having PF ratio above 200, list score of 1.8, an ICU stay together of 21, and a SEP score initially on 49. So it's a more severely ill group we included here. And what you see here, it's only a short-term protocol, so it's only the first 6 hours. And we look here at PF ratios, tidal volumes, CO2, respiratory rate, electric activity of the diaphragm. And what you see here, that tidal volumes, well, they tended, but they were not significantly different to the initial state. But we have to keep in mind that pressure support was really titrated in order to get to the 6 ml. So they kept that by themselves later on. And with regard to O2, SAT, or PF ratio, well, they were stable. There's no significant increase, but we have to keep in mind these patients were severely ill, and I wouldn't expect a huge change in this initial phase. So for us, interesting data. What we wanted to show is that it works to switch them on NAVA, and that definitely works in all of the patients and was uncomplicated. What was not that easy, but we will hear about that later, so I don't want to step in that too much, is the titration procedure. That tends to work out fine in a lot of patients, but there are some, we heard that yesterday, where it is more difficult, and judging the right point of the NAVA level was difficult for a lot of our physicians in many cases. Here you see the patients, and here are the physicians' choices of the right NAVA level. We did that in our ICU. So it's a bit of a difficult approach sometimes and has his problems, but you probably hear about that during the further talks. So another study to add the information, oxygenation. So now we look at 24 hours, 15 patients, Coycel study published in Physiologic in 2010, 15 patients, ventilation more than 48 hours postoperatively, abdominal surgery patient. You see here in this study that after 24 hours, there is an improvement compared to the baseline. So that's a bit in favor of NAVA. And it's also an increased biovariability of the ventilatory variables if you look to NAVA compared to pressure support ventilation. So what is else out there with regard to NAVA and the more stable settings? I think important information is the studies we already heard yesterday, the information on NIF and the information on sleep quality. And I think that is really important. And we will hear later on the aspects of weaning. Just to show you an example, this is a patient post-cardiac surgery, prolonged mechanical ventilation, tracheostomized, here on ventilation and here without ventilation. What you see here is a fast increase in electrical activity early on after disconnection. And we now did a small study where we looked at the signals in a TPEEP trial. And it's very interesting to see how patients behave that are not successfully weanable in terms of EADI marks or VT to EADI. So there's a significant difference in those who are successfully weaned and those who are not. So that is a clear, interesting signal towards using the catheter for monitoring. So in summary, what do we have on the plate? NAVA unstable patients. We have improved synchrony, so that has been shown throughout the studies right now. We have comparable gas exchange so far. We have improved sleep quality. We have effective unloading, and we have increased comfort in synchrony during non-invasive ventilation, and we have an additional signal for monitoring. So that are the puzzle pieces right now, but we have, of course, to wait for the outcome improvement in terms of mortality and length of ICU stay. So, and with that, I thank you very much for your attention.